Welcome back to the Sports Docs Podcast. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
On each episode, we chat about the most recent developments in sports medicine with experts from around the country. In this episode, we're going to continue our discussion with Dr. Bill Bugbee and focus on OCA surgical technique and then discuss clinical outcomes, including return to sports.
Our conversation picks back up with the recent paper from the July issue of Cartilage this year titled, Young Age and Concomitant or Prior Bony Realignment Procedures are Associated with Decreased Risk of Failure of Osteochondral Allograft Transplantation in the Knee. This retrospective nationwide database study represents the largest OCA cohort study to date and found that less than 2% of patients required salvage surgery. Young age, less than 29, and having a bony realignment procedure were associated with a significantly lower rate of salvage surgery, including revision cartilage procedures and arthroplasty.
We then finish up today with an article from the June 2017 issue of AJSM titled Return to Sport and Recreational Activity After Osteochondral Allograft Transplantation in the Knee. Dr. Bugbee and colleagues at Scripps Clinic in Jolla California reported that at a mean follow-up of 6 years, 75% of patients were able to return to sport or recreational activity. Patients who did not return were more likely to be female and have a large graft size. 25% of knees underwent further surgery, and 9 were considered to be allograft failures. Of the patients without OCA failure, 91% were satisfied with the results of their surgery. Are you one of the many surgeons who thinks that getting osteochondral allografts is a complex and time-consuming process? Well, you're not alone. But we're excited to tell you that there is a simpler way.
At JRF Ortho, they get it. They've heard your concerns and made it their goal to simplify the process. They're not just any company. They are leaders in fresh osteochondral allografts, holding over 60% of the global market share.
JRF Ortho is committed to accommodating your needs, delivering allografts usually around 30 days, and it's all on your terms. You choose your scheduling option, whether it's specifying a surgical date, providing a date range, or just requesting the earliest available allograft. Your preferences are their top priority.
And there's more. They offer pre-sutured tendons and meniscus, and ordering is as easy as a few clicks on their user-friendly online ordering system.
So why make it complicated when you can make it JRF Ortho easy? Simplify your allograft procurement today. Your journey to seamless osteochondral allografts starts with JRF Ortho. To learn more, visit jrfortho.org. So now we want to transition to the fun stuff, which is surgery. But before we talk about your surgical technique, which we're really excited to hear about how that's evolved over the years and what you're currently doing, we want to talk about indications. So you've been doing OCAs for a long time. What is your ideal patient for an osteochondral allograft transplant? Is it always including some level of bone loss, or are you using it in large cartilage defects? Like what kind of clinical scenarios are you using this in?
Well, so you might imagine I have a big salvage population with complex stuff, but, we were doing these in really, arthritis and osteonecrosis and even tumors and all this stuff before it became a thing in sports back about the mid-90s. But I really have a 5 criteria that I have this green really good and yellow maybe and red maybe no-go. And that's pretty important when not to do it. But the patient characteristics, if I was choosing a perfect patient characteristic, someone under 30, a quiet knee, in other words, not a big inflammatory synovic wet knee, with normal meniscus, of course, ACL, normal biomechanics, alignment is good. Mm-hmm. And honestly, preferring lower demand sports that not going to wreck their knee and re-injure it. And if you get all those right, and then a focal defect of the femoral condyle or trochlea, not patella, but trochlea or femoral condyle, then those are home runs. Our data on those ideal candidates is so good as 98%, as good as a hip replacement. But those are few and far between, right? So the reality is that I put them in boxes like traumatic cartilage injury, who's someone who's not had symptoms for more than a year and a half, because this chronicity becomes a problem. Osteochondritis dissecans the perfect solution. I actually think focal AVN in a young person is a good solution because there's no other solution for them except a total knee replacement. Post-traumatic disease, usually tibial plateau fracture, is rare but really good operation. Alan Gross published a lot on that. Those people are really happy, and they give them a couple decades before their knee replacement. Then you get into the yellow zone, degenerative chondral lesions, people that have maybe had an ACL done, maybe had a little bit of meniscus nibbled here and there. And, they're that knee that has Fairbanks changes, but has a focal defect, not quite there. Those aren't always successful, but when they are, the people are happy because you kept them out of the arthroplasty. And then the no-go is the advanced arthritis. We've tried that. Other people have tried it. Everyone with the hubris to say, oh, I'm going to treat arthritis for this. It makes complete sense to do this. And then they say, oh, my first cases were great. And then 50% fail. But I would still do that in the 21-year-old gal that, got chondrolysis and or something happened and got accelerated because they have no other solution. And if you get lucky, 50% of those are doing okay. You get them 20 years, that's a success. It may not be back to playing high-level sports, but they're happy people. So those are the boxes. But if you ask me one thing, I said it before, osteochondritis dissecans, because bone and cartilage. And you asked the thing about bony, I just mentioned the subchondral bone. When we first started doing these, all we looked at was the cartilage. How big is the lesion? No one cared about the bone. Now, all the action is in the subchondral bone, what's going on with that, right? And so if there's a subchondral bone abnormality, signal change on MRI, a big defect or whatever, that organ is unhealthy and you have to extirpate all the disease, not just part of it. And that's where the allograft has become so popular, because you can do that instead of doing a surface repair over some bad bone.
Right.
So any bad bone is an indication for an allograft over a microfracture or ACI, I believe.
Yeah, agree. And I also think those patients that you put sort of in the second bucket that maybe aren't ideal, it's a discussion. And, as long as the expectations are sort of understood that this isn't a guarantee that you are not a 98%. But, I think if I was in their shoes, I would sort of look at that and say, well, I understand the risks and the benefits, and I think it's worth a try. Knowing it's a big rehab, but, you're trying to sort of just give yourself more time.
It's really a shared, this is where shared decision-making comes in. It's what's your appetite for joint preservation? And, I get these patients as you do, and you can laundry list them. They got 6 things you got to fix. Are you up for that? Do you have the resiliency to get through all that, fixing all this stuff? Or are you just one of those people that you'd want to be one and done and most reliable? And arthroplasty is not the end of the world. They're pretty durable, and we've studied that. And they're the lowest reoperation rate and the highest, clinical effect if you do an arthroplasty or partial knee in that group of 30 to 50 like that. So it's not the end of the world coming from an arthroplasty surgeon, but it really depends on what the patient's perspective is on who they are and what they want to be.
So we were going to talk a little bit more about surgical technique. So as far as, prior using your x-rays and then you select your graft that arrives, do you have a backup graft there? Do you soak your graft in whole blood or pure P? Can walk us a little bit through, what's it like for you in the OR?
First thing I do is when the graft shows up, I make sure it's there.
Yes.
Before the patient goes to the OR, and I open the box and I look at the graft and I make sure it's the right graft. And I've only had one experience in my life where they sent an arthritic knee, and this was 20 years ago. But I've had a left and a right, or something not right that way. So you make sure the graft, or oh my gosh, this is really way too small, or something like that. So very rarely have to abort, but look at the graft. Then, you open it up, put it on the table before you cut the patient open. And I don't typically scope anybody because they've already been studied. I don't think you need to do that. I know a lot of my sports colleagues want to scope the knee first, but I really know. And I actually haven't gone to using the plugs that are available. I get typically a hemicondyle, or if it's both sides of the hole. So I have plenty of tissue. And I'm just dealing with pretty large lesions for the most part. So I just go to town. I mean, you get ready, you do it. The graft doesn't get special preparation. I don't warm it up. You know, that you asked earlier about whether cold to warm is bad. There's some studies about that, but pour it out, make sure it's not, I guess the most important thing is don't let it get exposed to air. That's been shown to be obviously not so good. So it's on the back tables in the fluid, in the media. And then before I'm ready to, you know, once I get the graft out, we can talk about that. You wash the heck out of it to get the marrow elements out. I think that's the bad actor, and either just with the pulse lavage or with the carbojet. And then you asked about what you soak it in. I know people have looked at the use of PRP or BMAC. It's easy, it's accessible. I mean, I've only done that a few times when I already have that available to help with an osteotomy or some other thing where I thought that BMAC would be appropriate. But once you put that graft in, it's going to suck all the blood out of the patient anyway. So getting that ready to accept, and, you know, the other principles I think more important, you know, tightness of fit, which is a variable, all the other nuances of doing it right and getting it right are more important than the graft at that point. And then don't whack it.
Yeah.
Yes.
I've seen that too many times. We're orthopedists, right? I have a hammer, our whole world is a nail.
Oh, man.
That's right.
Now, you mentioned tightness of fit. So are you typically doing press fit with no fixation? Are there cases where you've had to do a fixation? And if so, what implant do you use to fixate the graft?
So the vast majority are going to be plugs that are contained. I'll put a plug in that's only 50% contained, like in the notch for an OCD or on the side. And if you get a good fit, then it's fine. I think the thing, I rarely use extra fixation for plugs, even 2 plugs, and I don't make them thick. I think one of the biggest issues this is controversial, but I was trained to use as little bone as possible. So my grafts are usually a combined 6 millimeters thick, 5 to 7, 2 to 3 millimeters of cartilage, 2 to 3 millimeters of bone, and that's all you need to get a tight fit for the most part. If you do the 10 or 12 like an oat, that's way too much bone. I think that disrupts the biology. Where I use fixation is occasionally uncontained lesions, the whole patella if I do that, tibial plateau, something like that. But I rarely use fixation in the standard grafts. Can I use trade names? Can I use names?
Definitely.
Yeah, absolutely.
Arthrex instruments have a 1 millimeter tightness of fit between the harvester and the recipient site. So that gets you a fit that's almost too tight in the patella and the trochlea. You have to trim it. The MTF instruments are about a 0.5 millimeter. They're in between, and then the JRF instruments are line to line, so they tend to be a little, you could almost push them in with your thumb. But I think stability and fixation matters. So you got to know your instruments a little bit to know how tight it should be, but usually you shouldn't have to use any instrumentation or any extra pins or darts or screws or anything like that.
Yeah, I have the luxury of JRF is in my backyard. So they're in Centennial. I'm in Denver. And so one of the things that Ashley and I are trying to coordinate is a visit where we can actually go through the whole process with them and, you know, work with a lot of their instrumentation. And
so it's, you know, we wanted to study this, look at the tightness of fit. And again, the thickness of the graft informs you of the tightness of fit. More bone is tighter. And that's why the oat, which are 6, 8, 10 millimeters, need a thicker piece of bone because there's not enough interference fit. Yeah. So that's why sort of paradoxically, a little oat plug needs a thicker piece of bone than a big allograft.
Right.
And we can argue this. I know Dr. Gamal has some studies showing that thinner grafts have more cysts, but he uses a different instruments than I use. So his tightness of fit is less. So hydraulic conductance would let fluid get in between it if it wasn't tight. There's all these fun things that we're trying to figure out. That's what makes it cool.
Yeah, it's very exciting.
Yeah, absolutely. So you mentioned a little earlier about one of the 5 things that you look at in terms of putting people in boxes is alignment. and making sure that they have normal alignment. If they don't, typically, obviously, we're addressing that with an osteotomy. How prevalent is the use of osteotomies in your practice? Is it a lot of the OCAs you're doing, or is it pretty rare?
I'd say medium. I'd say in the presence of a healthy knee with varus and like it's typical, we did a study on the concordance of osteochondritis dissecans with varus or valgus, and there's a strong concordance with lateral OCD and valgus. But an allograft is such a simple, straightforward surgery and such a fast recovery in a young person. An osteotomy is a whole bigger work, right? Yeah, it's a whole bigger thing. So that's, again, shared decision making. We haven't yet been able to show profound changes if you don't do it. So in a primary knee with a little bit of constitutional varus or valgus, I might forego it, particularly if they want to go back to sport. But in a failure of a cartilage surgery, whether it's a microfracture, ACL, whatever it is, if they've had a failed cartilage surgery and I see malalignment as part of the deal that wasn't corrected, that's almost an absolute. So I would say less than 25% of the time in all comers, but in the yellow and red go, no-go zone, I'm always looking at the middle-aged person if I can just do an osteotomy for bipolar disease and they're happy. And most of the time, the scenario is a 35-year-old woman who lost her ACL meniscus playing soccer. You got 1,000 of those, right?
Yes.
And they show up in your office at 35 and they're DJD, joint space narrowing, no meniscus, and they're falling into valgus. That's a perfect distal femoral osteotomy patient, and I can treat them without cartilage and be happy. No meniscus, no cartilage surgery, and that osteotomy is powerful. So an osteotomy alone as a first step is fairly useful, but in an adjunct, almost always in salvage or secondary. And I don't do a lot of tubercle osteotomies, believe it or not. I think that's important. The allograft has the unique ability to change anatomy in the patellofemoral joints. You can create a trochlea with a big graft. You can change patellar kinematics by doing things so you don't have to unload it. That was the whole ACI story. It wasn't very good until they started doing osteotomy. So which is the effective treatment? Is it the osteotomy or the cartilage? And that osteotomy is not, people say it's great, it works, but you've all seen people that don't like it.
Oh yeah. So it's not without its complications and its risks, so.
Right. Absolutely. Yeah. So we have sort of two more topics. We know we've been keeping you for a long time. So we have sort of two sort of things we want to touch on before we let you be. So the last is, we've kind of talked a little bit about that difficult sort of window of time where it is someone who is, over 35, we're, not jumping towards an arthroplasty yet. Their alignment is fine, but they do have focal defects. Do you treat them any differently in a way that, as far as your approach to, say, graft selection, to rehab, to, anything to try and create more success there?
Yeah, I guess, what are their goals? I mean, when you get to that group, and these are the weekend warriors, the sporting type that are 35 and wish they were 21, they're trying to compete with younger people and what the belief system is about who they are. Mm-hmm. And at that age group, I guess the best thing I can tell you is I pull out the quality of life, the ADL stuff from the sports and recreation, and make sure they know. I kind of say, look, if you hurt in day-to-day life, going up and down stairs, or, you can't go on walks with your husband or family or whatever, you can't do the stuff that most people expect to do, that's the meat and potatoes. I can help you with that. I think I can get you there. But if you want to still play running, cutting, jumping, high-impact sports at 35, and this is the baggage in your knee, and you think a new piece of cartilage is going to do that, I'm not sure I can deliver on that as much as you think. So that's the managing the expectations. So I don't change my approach. I just change my, I'm fond of saying under promise and over deliver. Look, I'm not going to, you probably get better, and I can pony up a great bunch of great stories about high-level athletes that we fit like everybody else. But to me, that's not the metric. The metric is the average person at 35 who's looking at their future and looking at their knee that's got 20 years of baggage. Can I improve their quality of life? And what do they define as quality of life? Because I don't want to make them worse.
Absolutely.
So I think what we wanted to wrap up with today is talking a little bit about your post-op protocol. So post-operatively, what's your weight-bearing status, brace use? When do you start them in PT? Can you give us a quick rundown on that?
The beauty of the allografts are that it's simple as heck. It's so simple, right? It's like you put a piece of healthy cartilage that's best at time zero. You don't have to wait for maturation of a microfracture, an ACI. You don't have to worry about anything. And some of the best patients are the ones that didn't follow commands, right? I still try to get most of them, if it's a straightforward graft of the femoral condyle, just please use crutches for a month and go 25% weight bearing. That's sort of the simplest rule to give them. No range of motion. Patellofemoral grafts, I'll put them on a brace, tell them to walk in full weight bearing and extension for a month, but come out for do a little bit of bending. But they can walk fully weight bearing extension. At a month, if everything looks good, I let the people start weight bearing to tolerance, get on the bike, do all that sort of thing. But it's not rocket science. And I think that's when I tell people this after they've had an ACI or a microfracture. Is that it? That was the easiest surgery I've ever done. Now, it's a little different if you're doing a tibial plateau or meniscus, you got an ACL. So, for example, you do an ACL and an allograft. The ACL rehab is what drives it, right? Of course, that's probably the thing that drives it. You do a meniscus transplant and an allograft, the meniscus transplant protocol drives it. So that's a bystander. But a number of studies, a number of people that I know anecdotally of weight bearers tolerated and well-contained grafts and seen no problem. Dennis Crawford did a study on that, and maybe that's better. So we're moving to, and that's the beauty of, it seems like a big deal, but it's probably accelerated rehab compared to most other things and an early return to sports. I mean, I had a kid that was a high school football player, and he was back, and he was a college, he recruited at Division I schools, and he was back playing in 11 weeks. I said, look, you got to have functional recovery. Your leg has to be proven to be strong or you're going to tear your ACL or something. And then this other guy came back at 8 weeks. He said, I did a trochlear graft. And he said, Doc, I don't know what you did, but I could never dunk a basketball, and now I can. He wasn't even supposed to be, he was still supposed to be protected. Yeah. What? And this is how you learn that in ACLs, right? The people at Shelburne show the people that did the best just didn't follow all our precautions. But do a good surgery and they'll take care of themselves, I think.
Yeah,
so
certainly.
The rehab is pretty straightforward. It's common sense.
I was just going to say, certainly a lot less painful and different than an osteotomy. So
absolutely.
Yeah, a lot different.
Yeah.
So the last thing we always close with, we do something, Bill, at the end called the Fast Five. We just asked you 5 quick fire questions. Then we have the last question comes from our prior guest. It hasn't aired yet, but our most recent guest that we interviewed is Dr. Brett Owens. So he West Point onto Brown. So we'll close with that. And then we have you pose to the next guest a question for them.
Yeah.
Okay.
All right, Ashley, go ahead.
All right. So in the OR, foot pedal or hand control?
Hand control.
Okay. Me too.
What type of shoes do you wear in the OR?
Hocus.
Oh, yeah. I haven't tried those yet.
Oh, really good. Really nice. I used to use the clogs, all that stuff, but the Hocus are nice.
It's funny. I always recommend Hocus to all my patients, like foot and ankle conditions, but I myself have never tried them. But I
was a big New Balance person, so I got a high arch. I have cavus foot, wide front foot, and those were always, I couldn't wear the narrow Adidas or Nikes. And so New Balance would be fine too. Those were fine, but Hocus, they're the it shoe.
And then for the OR lounge, favorite snack that you're getting between cases?
So we have very poor snacking there. My favorite snack, well, we get these little packets of Jif peanut butter, the perfect food. So I speed eat those, but we don't get much better than that. So peanut butter.
Peanut butter. Okay. Well, what music do you play in the OR?
Wow. So I'm doing arthroplasty. I got the hood on. It's noisy already. It gets pretty busy. So I let the fellow choose. And unless it's
Nice of you.
heavy metal, I let them choose. So they get to choose. My last fellow had some really sort of low down country. They're from all over the country, and that's how I learned music, right? Just like I get my kids to give me a playlist every Christmas, every birthday, and that's how I stay up there.
That's awesome. Great. I love that idea. That's a great idea.
Awesome.
If
I don't like it, I'll tell them, but it's fun.
Yeah. No, that is really fun. We actually, so I have, side note, but I have 2 boys, and they're at ages now where, they're getting more interested in music. And that was something I did with my dad a lot in the car. He would, he really liked doo-wop. So we would go through all the different doo-wop artists. And so we're trying to do their music education now. So I like that idea of playlists.
I got a really interesting anecdote being fairly much older than you guys. So, guess that tune. Who's the artist? What year was it coming out? My daughter, who's 31, loves to do this. She'll say, what year did this come out? And I nail it if it's between late 60s, 70 to about 82. I'm uncannily good at knowing exactly the year. And you know why? Because high school and college, what you were doing, the soundtrack of your life, right? Oh, I danced to that at my prom. 84, forget it. Started medical school, no time for music. I can bits and pieces, but my soundtrack is those. So if you ask me, I listen to classic rock, but it's uncanny that you remember that, but you don't know anything else. So your kids will give you another generation.
They will. Hopefully it's good.
Yes.
Awesome. And then what's your favorite surgery?
Oh, my favorite surgery, hip replacement. For doing it or for doing it or for patients?
You can
an allograft.
Doing it.
An allograft for OCD is my favorite because it's fun, it's straightforward, it's easy. You see the problem, you fix it, you're done. You walk out of there, you're happy. Just like a hip replacement, they're going to be better. You just know, and the hardest part is dealing with patients that they can drag you down. But if we all want to hit home runs every time, wouldn't that be lovely?
Yes.
So OCD, allografts for OCD and hip replacement are my 2 twin loves.
Yeah, no, that's awesome. And then Dr. Brett Owens. So go ahead, Ashley.
I was going to say, do you want me to take this one? Because I did not put it on our list of questions. Okay. Yeah, so that was my bad. I'm sorry. So Brett's question for you was, how do you deal with bipolar lesions? He says this is a hot topic in terms of how aggressive you are and how you address bipolar lesions, let's say in that 30-something-year-old patient you were talking about.
So depends on the joint. I still do full ankle transplants with allografts for end-stage arthritis in people under 50 because arthroplasty is yet to be proven to be durable. That's a bipolar lesion. But you're talking about the knee, I suppose. Yes. And it really depends. So if it's the patellofemoral joint, my indication for patellofemoral arthroplasty has gone down, 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 down. So even in the mid-30s, I'll do an arthroplasty because otherwise it would take 2 grafts, a TTO, and all that stuff, a lot of stuff. And I found that a patellofemoral arthroplasty is more predictable. It fixes everything, fixes dysplasia, alignment at once. Tibiofemoral joint, fix the femur because you're good at that. You know what to do, even if it takes a few lesions. Ignore the meniscus on the medial side because the medial side is less meniscal dependent than the lateral side. Yeah. And if the tibia is accessible, usually I don't treat the tibia because it's so hard to access. Maybe a little microfracture, do whatever slurry, whatever little thing you want to do to get in there. Because I don't believe in doing these big, take it down just to get to a thing. Yeah. Like all my ankle allografts are done through a small anterior incision in the front, not a malleolar osteotomy. Lateral side, well, again, I guess I should go back and say always the osteotomy. Rule out an osteotomy for bipolar lesions every time because that's a disease burden in that joint. I'll ignore the tibia a lot and just fix what I can. And if I can fix 80% of the problem and I can, in my mind, say, I think the pain's from the femur, or I think multifocal too. I think people will fix the femur but forget there's a medial patellar facet lesion that's probably the actor. So ignore the tibia more often than you think because it's hard to do. We don't have a good tool. Under promise and over deliver.
Great advice.
That is great advice.
So not our next guest. It'll be a future guest. But Ashley, if it's okay, I thought we should maybe propose a question for Dr. Gamal.
Oh. Yeah, that's a very good one, Catherine. Okay.
Yeah. So not our next guest, future guest, but I think it's a good one to pin. Just
yeah.
I got a good one. New York or Boston?
All right, we're taking
New York
notes.
or Boston? What do you like? New York or Boston? Put them on the line.
Boston.
Come on, you guys get that one, right?
I like it.
That's simple, right?
That's an honest answer, though, because
that's an open-ended.
We were in Boston when he was in Boston.
I know. That's why New York or Boston. Come on, you guys. I mean, right? That's an open-ended question. The tell will be how he chooses to answer that: professionally, personally, financially,
sports.
So I would ask that one, and then I would follow it up with allografts or ACI, because he was at Boston with Tom, who's a good friend of mine, and you know him too, right? Yes. So they all were the this is my legacy. All these people were over there doing ACI and microfraction. I was the lone person, and they all thought I was a nut job. Now they're all doing allografts. So that would be my question: ACI or allografts?
That's great.
New York or Boston, ACI or allografts? What is it? How's that?
Perfect.
Does that work?
Yeah, that's awesome. Is perfect. We will be very excited to deliver that.
Awesome.
And, we both are, feel so grateful to have you on, and we appreciate stealing an hour of your evening. And I think, you shared a lot of great insight, not just for surgeons, but for physical therapists who, are trying to learn about these procedures so they can better take care of their patients as well. So, and the last thing I'll say is, I also really appreciate how you started, where you talked about honoring the donor, and we couldn't agree more. So thank you for pointing that out.
We forget what happens on the back end. We're so into the technique and this and that, but we always remember that you have to honor the gifts that are given to you. And the patients the same way. You have to honor the patients.
Absolutely.
That have trusted you. I mean, the last thing maybe I'll say, it's interesting. So think about what we do. We meet people for the first time. They're complete strangers to us. And in 10 minutes, 15 minutes, they agree to let us put them to sleep, cut them open, and put something in them that they know nothing about. There's nothing else in the world that allows you to do that to somebody else. And so you have to honor that. And that's why I try to not do harm and may sound like an aggressive surgeon, all this crazy stuff I do, but you have to honor and respect that people let you do it. It's an amazing concept when you think about what you do. So I think that's a privilege, and to be allowed to do that, you have to honor that and do the best you can every day.
Yeah, well, that's very well said. Thank you. Thank you very much again for joining us.
Sure, love it. Thanks, guys.
All right, well, have a wonderful evening, and thank you again.
Okay.
Take care.
Good evening. Take care, guys. See you later.
Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and now on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or a comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod and Twitter at thesportsdocpod. We love your feedback.